grade for years and years and years and never change. But you watch it because they can degrade into high grade GBMs. And the one thing, they can look at like a butterfly lesion, and that's where it crosses the corpus callosum. Here is, we indicate right here, so that's what they call a butterfly lesion. It's pretty much indicative of not good prognosis, and it's indicative of a GBM or a glial tumor, a glioblastoma. And these are just more examples of, you can tell this is just the non-contrasted study, but when you look at the T2 aspect, see all this swelling and edema around here. The tumor itself is right around here. Another obvious feature of GBMs, they've got this wall of tumor around here, but inside it's all necrotic. So this is all dead brain tissue. So it's really invasive and it chewed up. Sometimes they'll actually involute just out and collapse on themselves. But that's one of the distinguishing markers between kind of middle grade and high grade is whether they see necrosis. The pathologist is actually looking for necrosis on the cells. When we send a specimen, we're trying to send them just the edge, just the border of the edge, because we want to, because otherwise, if they see just a bunch of char or a bunch of necrosis, they can't really tell. But they want to see if they see glial cells that are transforming, that they have a high rate of mitosis, high rate of cellular change. Okay, so infratatorial tumors again. Those can be cerebellar astrocytomas, and then medulloblastomas. So the cerebellar astrocytoma, they're usually cystic. This is along the lines of the pilocytic astrocytoma. Most common in childhood. These are usually curable, about 90-95% curable. The only reasons they usually aren't is if they are affecting some of the cranial nerves. They affect the cranial nerves and actually get into the hypothalamus, and they can affect their temperature regulation. So that's kind of where the 5% mortality rate comes in those patients. Medulloblastomas, again, these are in the base of the brain, infratatorial, the base of the brain. Second most common posterior fossa tumor in children. I don't know that that's that important. All concerned about most common and second most common. Mainly just remember the most common. They usually arise from the vermis, and they down there in the cerebellum you see increased intracranial pressure issues because they'll occlude that fourth ventricle and cause the hydrocephalus. Okay, so let's go back to this medulloblastoma. MRI reveals contrast-enhancing midline paramedian tumor, which revolves in compressing the fourth ventricles. So, they're heterogeneous and may show evidence of some necrosis or hemorrhage or cystic change. So, now, this will be kind of easy. We're skipping forward, but what is this tumor? GBM. It's a GBM. And why is that? What is that lesion? It's 40 to 60-year-old male, very malignant butterfly lesion. And now, what is this one? Yeah, it's a meningioma. So we've got second most common brain tumor, rises from rhabdoid cap cells. Okay, wait for a second. You skipped back, you cheated. No, yeah. So this is highly radiosensitive, second most common tumor in children. This is a medulloblastoma. This one, okay. Usually this one occurs in young adults, and it's 15% of astrocytomas, so it's just a low grade. So, all right, a couple of, I took this talk over from someone else that probably did a much better talk last year on it, but no. She did recommend it. There's a surgical recall book that's really good for general surgery rotations, but if you're really, and it's got a bunch of kind of pimping questions that you get, but it's actually pretty good for board questions too. They kind of have those stereotypical questions in there. But anyone really interested in neurosurgery, and most of this data where we got is from the Handbook of Neurosurgery by Greenberg. And that's kind of the Bible for neurosurgery. You can look up anything and everything in there. It used to be in 2 volumes, now it's one really big volume that you can't carry around. it's actually not too bad, it fits here. We've got a couple of other syndromes in here, like Werner syndromes and Pons. You know, if there's a tumor in your Pons, what happens? But one thing I did want to point out, from our standpoint, this very top one, the oculomotor nerve compression. In our in neurosurgery, if there's a unilateral dilated pupil, if one dilated pupil that's fixed and dilated not working, from our standpoint, that's a PCOM aneurysm until proven otherwise. That's kind of not the brain tumor talk, but it's the posterior communicating artery goes right down through, right by the third cranial nerve. So you pretty much have to do a CTA or an MRI to prove that. If you've got somebody with a unilateral dilated pupil, either if they're neurologically intact, either they're herniating, they got a lot of pressure on one side of their brainstem and they're dying. You got to give them mannitol or put a drain in to take some pressure down. Or if they're neurologically intact and doing okay, we're like something else is going on. So you got to do some kind of vascular study to look to rule out an aneurysm. That's just one of my old attendings was pounded that into her head over and over again. And this is just a little cheat sheet on your Glasgow-Coma scale. The GCS, you got your eyes, your verbal, and your motors. I think a little cheat sheet is eyes. It has 4 letters. Verbal or words, saying words has 5. So there's 5 points for words, and motors with an S has 6 points. So 6 points for motors. Right?
So the oculomotor nerve compression, is that like specifically like if there's no trauma? Because I know concussions look like something I look for.
This is with no trauma, or the PCOM aneurysm. I mean, it can be with anything, any kind of compressive lesion. If they can have trauma and they've got head bleed or they've got damage in that area, they could damage the third nerve. But in our case, that's just very close to where the PCOM, posterior communicating artery, travels. So that's just, if there's an aneurysm, it's putting pressure on it physically. Other brainstem issues, I mean, you can have your pressure on the trigeminal nerve, which can cause trigeminal neuralgia, atypical facial pain, and there's actually surgeries where they go in and they'll go in through the, basically go make a decision, go in and they'll sometimes put a little Teflon pledge it right by the little blood vessel. There's usually a little vein or an artery going right by the trigeminal nerve. That's the one with the 3 big trunks on it. And you can put a little padding on it. Sometimes you just go in and you zap that. You just cauterize that blood vessel. It'll shrink up and they won't get that pulsating thing. And patients really do well on that. I mean, that's the one you're supposed to give everybody Tegretol, and it's for the trigeminal neuralgia, high-dose Tegretol, and you got to check them for agranulocytosis. But surgery actually works pretty good. They'll do gamma knife surgery or gamma radiation surgery, but we have one of our partners that actually does quite a bit of trigeminal nerve surgery. They do fairly well. Other compressive lesions associated with altered local conscious strokes, which I know Russell talked about yesterday. You get massive hemispheric ischemic stroke with cerebral edema, and I've got a brief picture on that. Cerebral hemorrhage, cerebellar infarcts, infections, or trauma. She questioned her. So this is a lady that I actually am going to see in clinic tomorrow. I just got back. We saw her about a year ago. They did a CAT scan of her. I mean, she came in with headaches, a little dizziness, nausea, and her original scan they thought was a cystic meningioma because it had all this fluid and quite a bit in there, or quite a bit of other tumor in this same area. But it was, this whole thing was all cystic. And everybody's like, oh, it's cystic meningioma, she's doing fine, just a little headache. But we went in and it's a GBM. But she was 57 at that time. We did the surgery, she did really well, didn't have any deficits. She did 6 weeks of radiation treatment with Timidur, which is a chemotherapy agent, and then 6 months of Timidur in the chemotherapy agent, and did really well. And she followed along with oncology and radiology with repeat scans about 3 months, every 3 months, and then 6 months. Then about 3 months ago, they started seeing some growth back around in the tumor bed, and that's where the recurrence will usually occur on a GBM, because that tissue, again, it's an infiltrative tumor where it grows in the normal tissue. So even if you went in and you could tell where it's going to be, there's no real good studies that say, hey, if this is where the tumor is, you could just take out a whole bunch of normal functioning brain, because you're going to give them a big deficit. And so you got to decide, well, statistics are they're going to live about 12 to 15, 18 months. But one of the indicators of how well they're going to do is called the Karnofsky score, which is a scale from 0 to 100, but 100 is essentially a normal, high-function, normal person, you and me, well, maybe not myself in some days, but if they're not having mental deficits, or if there's confusion or disorientation, they're at a 99, so I probably run about a 99 most days. So anyway, they ran repeat scans on her. With radiation, you can get actually radiation necrosis, so they don't really know initially when they did that scan 3 months ago, oh, is this necrosis or is this recurrent tumor? So they do an MR spectroscopy that has to do with the it has to do with the choline creatinine ratio. And so essentially we get the radiologist to do an MR spectroscopy and they tell us, this looks like radiation necrosis, or no, this is real tumor. And in her case, it's real tumor. So she's coming back in the office. She lives a few hours away. So she's coming back in on Wednesday. We're going to talk to her. I already talked to her on the phone. She's going to come with the family. We're going to do her surgery again on Thursday. So take her back, and it's probably going to give her hopefully another 6 months more of symptom-free. But at some point, it'll continue to keep coming back, and we'll kind of have to go, well, there's only so much you can do, and people get tired of dealing with surgery. But she's done well. She hasn't had a lot of deficits, and so we'll keep treating her as long as she wants to be treated. Now, this last one I said I talked a little bit about pituitary masses. This is okay. So this is the coronal view. We're coming right back in, right behind the optic chiasm, right back from the nerves. This is sagittal view coming in. You've got a big mass right through here, kind of obvious. And came in with visual disturbances, and this. So there's the coronal view, sagittal view, and the axial view. You can see where the optic nerves would come back across the optic chiasm and the optic tracts would come back. So, does anybody know what the condition is called when you have compression right on the optic chiasm, and when you can't see? And yeah, it is hemianopsia, but there's a couple different types of hemianopsia. So this one, it's bitemporal. So bitemporal hemianopsia, which you can get homonymous hemianopsia, which is they cut off one tract, so you're just losing one side of your vision, one lateral visual field. But in this case, the stereotypical pituitary mass, it's either going to be a pituitary adenoma usually, or a craniopharyngioma. And pituitary masses in general can be endocrine secreting or non-secreting. So the secreting ones, you can have growth hormone, ACTH, TSH, prolactin. Prolactin is the most common secreting tumor, and that one actually can be treated medically. You don't have to do surgery. You can give them a dopamine agonist, which is going to stop prolactin. So bromocriptine or Carlidel is that's the one that you don't actually need surgery. You give them that medication, and it shrinks the size of the tumor. So what's the brain surgeon's out of business? We got plenty of business. There's plenty of back pain to go into. This is, so that same surgeon, another one of our partners that did surgery on this patient. This path actually was a craniopharyngioma, but they did a transphenoidal approach, which means usually we're talking about craniotomies or taking a piece of the skull off. But in this case, they through the nose. So they put a speculum, just a nasal speculum in there. And we'll do this in combination with an ENT doctor. He'll help us get the exposure. He'll go in and take down the nasal septum and move it off to the side. They'll do, some ENTs will still use cocaine. They actually use cocaine for vasoconstriction, but most doctors will just use Afrin and use that. And so you can see the speculum's in there now, and now this is a big retractor that actually holds in place. That's just a little suction that goes back to the base of the sphenoid sinus. So you're at the back of the wall of the sphenoid sinus right here. And now we'll use a drill or a kerosene to cut away the chips of the bone to access where the cella is and where the pituitary is. And so that's just a little bipolar cautery agent, get some bleeding in there, and get the bleeding under control before we go. And then now, look how far back she went. Okay, we're right here. Now, bam. Oh, okay, we're all the way back in the brain this far. So this is all in the cella. So this little suction device, and that's just a little ring curette. It's essentially a little tube that you go in and you just scoop out little pieces of tumor. And pretty amazing that these patients can handle this without too much problem. They just put a little mustache, they'll use some nasal packing or a mustache dressing, which is just a little dressing goes over their ears and hangs on there. You can get a spinal fluid leak in these kind of cases. Usually when we're doing a regular craniotomy, we take the skull off, open the dura up, we close the dura back down, and then put DuraGen, which is a replacement, maybe some DuraSeal. It will scar back down, but we'll stitch that all back together. When you're inside the pituitary, inside the nose, there's not a lot you can do, so usually they'll just do some packing. They'll just use some nasal packing, and that will usually block itself off. But in some cases, even some trauma cases where they have fractures at the base of the skull, they can get a spinal fluid leak, they strip it out their nose or out the base of their ear. And just real briefly on one of Russell's cases from yesterday, there's, again, not probably the talk for brain tumors, but it's got one more thing here. This patient came in with the right MCA CVA strip, so weakness on the left, no speech issues. Originally on a CAT scan, you don't see any real deficits. You can't see any real edema or swelling. There's really not a whole lot go on. So acutely on a CAT scan, you can't see a stroke. So they get an MRI. So they get an MRI, you can see that. But when you go the next day, the second day you start to see there's a lot of swelling starting to occur on this second and third day, and it's trapping that ventricle. This is the right lateral ventricle. Starting to smash. You're starting to have some midline shift, which is this just a mark of the midline. So it's going from one side to the next. This is the next day. We've got even more. We're like, okay, now we're getting enough pressure. And you can see which part of the brain, it's actually, all of this part, it's a large MCA CVA. So that whole part of the brain is essentially going to die. When you're old and you have a stroke, you had atrophy, the brain atrophies, so you can handle a little extra pressure, a little extra swelling. Now, when you're young, and essentially the cutoff is about 60, if they're less than 60 and they have a non-dominant hemisphere stroke, a right-sided MCA CVA, you can do what's called a hemicraniectomy, where literally you'll just come in and you'll shave off the bone. So you just take off the bone, you cut it out here and here, take it out, and you put it in their belly. You literally take the skull off, you leave it in their belly, or you put it in the bone freezer. So you wrap it up, but you actually do an incision and leave the skull in their belly, and then it's not going to change, or this will prevent the patient from dying. It's not going to change their outcome from the stroke. They're going to heal, but it's the one life-saving thing you can do from a stroke standpoint. If they're young and healthy, they don't have any room, so they swell up, and you let the brain just swell up, and then 4 to 6 weeks later, that tissue all dies back down. You come back in and take the skull out of their belly and put it back on. So it's really pretty interesting. But all right, kind of ran kind of fast, talked fast, but other questions?
So for a brain biopsy, do you go into the nose as well?
Usually we'll do that stereotactic deal where we set them up in the pins and we find out exactly where we are, and then we actually pick a target on that stealth machine that says this is where we're going, and so we've got this biopsy needle that kind of almost is like Star Wars are like stay on target, stay on target. So you're just going, you're like, okay, you got 5 more millimeters, 10 more millimeters, so you get right down to the next spot, and then you're so we know, and we got this little inside this stylet, there's a curette, there's an opening that's about 5 to 10 millimeters that you can get you can scrape, you turn it on the end of it, and it scrapes it, take pieces of it, and you take it out, you flush it in there, and you send that off to the pathologist, and then we kind of wait around 20, 30 minutes twiddling our thumbs when we go make sure we're in the right area, make sure they give us stuff. But again, like I said, in those areas you can kind of tell, oh, this doesn't look like normal brain, so we're probably good. But you want to make sure you get diagnostic tissue. Other thoughts or questions?
So when their skull is in their belly,
You don't go.
like are they like still?
We leave them in the
Are they
ICU for the first couple of days, for the first few days, and then we get them a helmet. We get them a little rubber helmet to where they've got this little helmet. It's not like a motorcycle helmet, but essentially there's a fancy, like an orthotist that get fitted for braces and back braces. They'll make them a helmet, so these patients have to, when they get out of it, we make sure they wear their helmet. We put up craniectomy signs that says don't touch the right side of their brain, or if it's the left side, we'll do the left side occasionally, but usually it's the right side, because if somebody's got that large of a stroke and it's on the left side, which is the speech center, that's going to be dead. It's going to be gone. It's probably never coming back. So those patients that are 50, 60 years old and have a big stroke like that, that's kind of where they go, okay, quality of life, okay, this person may heal, may recover, but they're probably not ever going to understand what you say and not going to be able to speak again. So the American College of Neurosurgeons or the American Stroke Association essentially has these guidelines of right-sided, non-dominant hemisphere strokes. You can do a hemicraniectomy. But we'll give them a helmet. You know, when we put it back on 4 to 6 weeks later, then take their helmet off.
So they go like run around.
They go run around. Well, usually they're
Well-
severely hemiparetic, so they're usually in a wheelchair. But you know, you got to be careful with transfers. I mean, you don't want to drop somebody, and you don't want nurses turning them on their side, putting pressure on their head, because these patients are already, they've got tons of pressure. Even with this, we've taken their skull off. You get external brain herniation. You'll get external herniation, where literally the brain is outside of the skull, and you can feel it. So we've got a head wrap on there. You try to not put their head wrap too high, because in some cases, we'll actually have an intracranial monitor, or one of those drains I talked about. We'll put the procedure, I drill a hole in here, and you slide a tube into the ventricle, and you can assess the pressure in the brain, and the normal pressure is anywhere from 0 or 5 to about 15 millimeters of mercury. And you can lower and raise this drain so we can drain out more fluid, or let them reabsorb the fluid on their own. But essentially, these patients still are going to need mannitol and 3% to try to bring the swelling and edema out. But really, we're just trying to prevent them from dying, to let them get through that acute phase, which is the first day. They don't have a lot of swelling when they have a stroke, but it's day 3 to 5 or worse. But about day 5, that's when the swelling is the worst, and these patients are going to die. So we don't like to rush them through at that point and say, hey, we're emergent running in. We know if somebody's young and healthy, they had a big stroke, day 2 or 3, we better talking about, hey, let's talk to the family. Do they want to do this surgery? Do they want to do hemicraniectomy? Because it'll save their life. It's not going to, it's not going to fix their damage that they had the stroke. Stroke's damage is done. Now, they may do interventional procedures where they'll go in and try to retrieve a clot, to try to open up the vasculature to heal the stroke that way. But after that stuff's been done, there's not a whole lot else left to do to let them heal from the stroke. Any other questions? No. How about, I guess, day-to-day life of a neurosurgery PA? We come in and I've got a pretty good doc. There's 2 PAs, like I said. We both work for the doctors. One of us is in clinic, 2 days a week. The others switches out. I do surgery all day with my doc on Mondays, so we do 3 or 4 surgeries. We don't really start till about 9. So I'll go in and round a little bit, see a couple patients, go see the pre-op patient. I keep my job because my doctor doesn't know how to do anything on the computer. Okay, so I can log in and make sure his H&Ps are up to date and orders are all good. So, but Brett and I, we see all the patients. I mean, our doc literally he sees 3 or 4 patients in the morning, Tuesday, and 3 or 4 patients on a Wednesday. But we try to put up on Tuesday and Wednesday morning. When I'm in clinic on Tuesday or Brett's in clinic on Wednesday. We try to put in all the new patients on those mornings. So if there's somebody surgical, we'll do the workup and kind of work through some stuff. But we'll introduce it. Okay, hey doc, there's a surgical patient, because they kind of get tired. Surgeons like to cut, and they like to do surgery, and they don't like to deal with all the post-op complications, post-op issues. But so we'll see the patients. We'll talk to them. Go ahead.
Do you work in 601 in Baptist?
Yeah.
Okay, my wife works there. I was just wondering.
Yep. That's our main ICU.
Nice.
What's
Okay.
her name?
Shannon.
Yeah. Okay. We've just now recently hired 3 neurointensivists that actually I kind of used to. I had an attending that he did all the intensive neuro work for a while. So he kind of trained me, and he left and went off to Chicago. So I kind of did that for the last few years. But now they got the 3 neurointensivists, and they're much smarter than me. So they're running at a Karnofsky of 100, not 99. So they help us out. But really, we'll go in and do 3 or 4 surgeries. And in surgery, I'm setting up the patient, pulling up the films. The anesthesia intubates them, but I help the nurses get the patient on the table. I'll pin the patient if it needs to be done. We'll position, get ready to go, shave, prep, and then help drape the patient. And then we call the doc, hey doc, we're ready. So they come on in, and then we'll do a timeout, and then do the incision. So he usually does the cutting, and he'll drill the bone in most cases. But we'll suction and keep the brain moist and kind of suction out stuff. We'll take biopsy samples. But then if we're doing like a shunt, so a shunt is essentially where they're putting a tube in the ventricle in the brain, and it's for permanent placement, and it'll drain down into the belly or into the vein. So the doc will do the vein part or the belly part, but I'll do the head part. So I'll come in and make my own little incision and drill and put the tube in and pass it under the skin. I let him do the part where there's a big passer that goes from here to here, because it looks poor form if I jam it into their lung because of the thorax.
Did you do a fellowship or anything after school, or
Nope.
were you trained?
Nope,
on
we
the
trained.
job?
My first day on the job, I was drilling a hole in somebody's head. They were like, oh, you got blood in there. So they're like, go for it. So that's why, if you're rotation, seriously, my goal is to get the students drilling holes in somebody's head. I mean, doing stuff, you get in there and you see patients, I mean, and you're round for, it's like I've got a student this month, but she's rounding and they did a surgery this morning. Usually it's not the line, but this morning they gave us 7:30, so we don't like that. And then I'm ignoring this right now because I am actually on trauma call today, so I do take call for my doctor, so they pay us a little bit extra for that. I don't really like that, it's not worth it, but it's helpful. It keeps him working, so he'll work for another 5 or 6 years for me, so that'll work. So, but he's nice to puts up with us. And so, and then when he's done with the surgery, we essentially close up, so we do all the sewing and the tying, so you get to learn to sign, you don't learn to speak on my rotation, you learn to sew and tie. And then we see him in post-op, recovery on the floor, and then send him home, and then see him 2 weeks later, make sure the decision's good, and then if somebody has a neck or back surgery, you know, we'll see him a couple months later after that, probably 6 months later. But then brain stuff, usually we get the other team, the oncologists or the radiation oncologists are involved. So once that, we make sure the patient's wounds are healed up enough, because if they do radiation and chemo and steroids, those all can affect their wound healing. So we don't want to have somebody end up having a wound infection like that one guy that kept picking at his wound. So we kind of give the clearance, and once we say, hey, the wound looks good, take out the staples or take out the stitches, and we say, okay, now they can do radiation or chemo. So, other than that, other questions or thoughts? All right, thank you guys.